The two most interesting area for drug development, actually there are three, but the two most interesting, most pressing are the HER2 amplified tumors. We're seeing a lot of great signals, and there are a number of studies that are looking at the HER2 amplified tumors. Across the board, we're seeing those studies inducing significant responses with dual HER2 blockade, usually an oral and an IV agent. So trastuzumab plus lapatinib was the first study, looked very interesting, small study. The next one that's reporting out is Heracles B, which essentially is trastuzumab plus pertuzumab, and then there is my pathway study with trastuzumab and pertuzumab. As I said, there is the tucatinib plus trastuzumab study that's ongoing. All these studies hold their promises, and we hope to have a standard for our patients with HER2 amplified tumors soon. This is 4% of the patients, so a reasonable chunk that we need to pay attention to. So that's one. The other option or the other area that I think is very exciting is immune therapy. We had a big disappointment with Emblaze 370 that looked at essentially atezolizumab and cobimetinib with the hopes that this will transform cold tumors to hot in the microsatellite stable space. This was negative. It really put a lot of, in addition to this disappointment, slowed down the progress in this particular arena, but did not and should not stop continue to developing options for patients with microsatellite stable colorectal cancer that may still be eligible for immune therapy options. So some of the more recent studies include agents that target pathways other than MAPK that essentially increase the level of tumor infiltrating lymphocyte proliferation into the tumor. There's also the macrophage inhibitors like CSF1R inhibitors that are being combined to PD-1 inhibitors and essentially bringing those good macrophages into the tumor and excluding the bad ones, so shifting the balance and increasing the level of antigen presentation and likelihood of these PD-1 to be available, and a number of other permutations in colorectal cancer that would allow essentially, hopefully one day, immune therapy to make its way into microsatellite stable colorectal tumors, in addition to the advantages we've seen with MSI high. Finally, there's also the other targets, and there are a number of them that are being looked at, and a lot of them are being developed. We have a specific platform going through our Accrue network, which is a Mayo Clinic supported consortium of about 100 institution and private practices, community practices, that essentially is trying to look at breaking down colon cancer into a lot of different diseases and finding a target for each one of those disease subgroups, a study we call Colomate. And we already have a number of studies that have been built in addition to the HER2 study, into this platform, and continue to build that. So this is the future of where we want to go with this disease. And I think we're just seeing the tip of the iceberg right now. The rest of the iceberg is going to become clearer and clearer with time. And I think ultimately we're going to be able to target every subgroup of colon cancer with the appropriate agent or combination of agents.
As we learn more about the molecular profiling of patients with metastatic colorectal cancer, we have found that certain targeted agents hold promise for treating patients. So we think about things like HER2 positive disease responding potentially to HER2 inhibitors. We saw from the Heracles study the combination of trastuzumab plus lapatinib giving response rates in the 30 to 40% range for these patients with durable responses. And we saw in the My Pathway study the combination of trastuzumab plus pertuzumab showing response rate in the 40% range, again with durable responses. So showing that for this particular population, these targeted agents hold a lot of promise. Another agent that we're very excited about that's shown some initial promising data is something called CEA-TCB. This is a bispecific antibody that binds to CEA in the tumors and then binds to the T cell receptor. And so bringing the T cells to the tumors directly. And we've seen some preliminary data with both the single agent bispecific antibody and this bispecific antibody in combination with atezolizumab that has shown some responses in patients with refractory microsatellite stable colon cancer that are very durable. So we're waiting to see more what happens as this molecule gets developed further.